Hello, hello, hello. Good evening. I am Marguerite Dunitz-Scheer from NoTube, and I'm talking to you tonight from Zurich. And I hope you can hear me. Please use our chat function to also comment on technical issues if you can't hear me or can't see me. We will be talking tonight about... Yes, of course, question and answered. We're going to talk about the NoTube eating school, and I'm going to, in just a few seconds, the number of participants is rising and they're just coming in the door. So we'll be very happy for the next hour to focus on the work of the NoTube team and group, which is happening in the eating school, which is a kind of day clinic in Austria, in Graz, which is 2 hours south of Vienna, and where we organize and manage 10 eating schools per year, 10 eating schools of 2 weeks each. So it's mostly 2 weeks interval, 2 weeks eating school. And in every eating school, up to 10, sometimes even 11 families, including always both parents, if possible, sometimes grandparents, and also the siblings. So every group of each eating school is a completely unique new mix for us of ages of children, varying mostly from about 6 months up to normally about 5 to 6 years. But in nearly every single eating school, we have exceptions. And in the last eating school, we had a young lady, 16 years old, from London. So it's a very inhomogeneous group, but our team is very used to this. And we also believe that the diversity of diagnoses, of cultures, of countries, of ages is one of the absolutely positive single variables which makes the kind of special therapeutic atmosphere of the eating school. The eating school itself was developed when my husband and I were still working at the University Children's Hospital, where we headed the award called CEDU ward, which means Severe Unit for Eating Disorders Children. It was a ward where we got patients from all over Austria, aged 0 to 18. So some children suffered from life-threatening conditions like infantile anorexia. Some children had months of very intensive surgical or cardiac or oncological treatment, and started at 4, 5, 6 months in age. And then the big group of toddlers with more behavioral and highly selective eating, picky eaters, up to children with early onset anorexia, and then the whole range of what we call classical anorexia, which in Austria and Switzerland is becoming a diagnosis affecting children earlier and earlier in the past 10 years. So many of our patients coming into our so-called weight dog program are only 10 or 11 years old. And about 50% of the NoTube patients per year visit our eating school, whilst the other half of the patients we treat online. But this is not going to be the theme tonight. I'm going to really specifically focus on the eating school, and I very much invite you to ask questions, especially maybe general questions, which I'll try and cover. And also tell you that if you have a specific medical question or specific question concerning your own child, we have the option on our website, notube.com, called free evaluation. And this is a very, very daily used very wonderful option, I find. It's a 20-minute interview with one of our very experienced team members, evaluating the question whether the mother, father, and the team member thinks that our program might be suitable for your child. And so I won't be talking about specific single diagnosis tonight, because we could fill an evening with autistic spectrum children and their specific difficulties, with children with Down syndrome and their specific children after cardiac or esophageal atresia. But this is not going to be my main focus. I'm going to try and give you an impression, an overall impression of the specificities of this eating school, which, after being able to compare years of experience within a hospital where we were able to organize what we felt at the time was very much by us influenced setting. Like, we introduced the play picnic, we introduced video diagnostic, we introduced group therapy with toddlers and babies. There were a lot of things which we could influence, but we really only after leaving the hospital by retirement started noticing how many things were not able to influence at all. And we tried then very much in the first years since 2016, when the eating school started. We've had now over 60 already in the meantime, to adapt our program more and more, and every time new, to the needs of the children. And the general package is arrival of the families on the first day at 9 o'clock, after mostly traveling for at least one full day, sometimes even two. All the patients, practically all, don't come from Austria, but come from all over Europe, from the south and the north, from Scandinavia, even some from America, some from the Near East. And so we have an international airport in Graz, and there's also an even bigger one in Vienna. So from Graz, it's only half an hour. From the airport from Vienna, it's 2 hours. But the first day is mostly a little lively, I would say, because 10 to 11 new families are meeting each other in different languages, don't know each other. The children are crawling around, hopping on their parents, running, walking. Most of them feel safe and somehow seem happy and not too much anxiety. But the parents, of course, are very nervous, I would say, and anxious to hear whether we think that we will be able to help their child. Now, in our assessment process, which precedes the traveling to the eating school, we take great care to assess what we call the suitability of a child for this program. There are certain risk factors when we think we can't take a child. One of them is if children suffer from severe immune deficiency. That would be a reason not to be able to join a mixed children's group, for instance, after long oncological treatment, or if a child has a congenital immunological deficit. A second reason might be that a child has very severe autistic spectrum and might find it difficult in the first days to kind of tolerate the group and the new situation. But usually these things can be dealt with. And then the main medical reason, which we must be sure of not accepting, is children who really suffer, this is very rare, from real dysphagia, which means they cannot swallow. And this is in 99% a neurological problem, caused sometimes post-traumatic after surgical interventions, but some children are also born with a primary dysphagia. and they are characterized by not able even to swallow their own saliva. So if you have a child who cannot swallow their own saliva and is drooling all the time and is wet all the time, awake and also in sleep, then this might be one of the rare reasons, which happens about 1% of all children referred to us, that we have to make the judgment that it's probably not sensible and safe to come to Graz. But usually they are suitable because parents, I think, are very sensitive in really having an intuitive estimation of whether their child is ready for the next step, whatever the next step is in each child. So they arrive. The first day we call the assessment diagnosis day. We call it the diagnosis street. And in 4 different rooms in our eating school, which is quite a beautiful villa. You can see it on the website, also in a film. There's a kind of a tour. Small teams of NoTube therapists are looking and evaluating the child from the medical perspective, from the psychosocial, psychotherapeutic perspective, from a kind of functional, physio-functional, occupational perspective. And the last one is from a social practical, a member of our team helping and supporting the families if they need any help in finding their accommodation, their apartment, their hotel, if they need any specific additional support, a pram, whatever. And after this very first day, we have a big team session in the evening and try and make a draft, I would say, of treatment planning for each of these 10 patients for the next 10 days. And in this treatment planning, we will decide which general approach we all think is going to be beneficial for the child, and which child might or which parent might need possibly also individual single sessions. So this very much depends on how the child presented itself and with which skills we felt that the next step needs to be supported. And after the first Monday, really the days are structured very much the same every day. We have 3 big play picnics, a breakfast play picnic at 9 o'clock, a lunchtime play picnic with warm food, cooked food by our cook, and an evening play picnic at 5 o'clock. And these are group meetings where the children join their parents, or at least one parent, in the group and meet food in a very different way than these children have been used to meeting food. So the food is at the beginning mostly on the floor. They can all sit on the floor, they can crawl around, they can touch all the food they see, whilst the parents take the food they want to eat from the buffet, which has been very attractively set out for them. And we don't interfere. We kind of try and observe the child and its family, and also the interactions going on between the child and the parents and the siblings. And we try and more or less keep in a discrete second row. But if anything goes on where we feel we need to or should interfere and make a comment, of course we do that. Mostly about 5 or 6 team members are in the room. So we absolutely don't have the kind of classical single encounter situation, which parents and children know from classical therapies in hospitals and in institutional settings. Most things going on happen in the group. And this is because we, on the one hand, my husband and I have both education and training in group therapy and in group dynamics. And it is quite remarkable to see how sensitive children react and how observant they actually are from the age of maybe 5-6 months. As soon as they can sit stably and look around what's going on, they are incredibly observant to what's going on the level of the other children. This seems to attract their interest much more than watching their parents, which they know. And also it helps the parents be a little bit less intrusive and less pushy and less active than at home, because there's so much kind of going on in the room. And if the parents don't feel secure about something, they will ask one of the team members, and immediately there will be a kind of intervention or a comment. Now, these 3 main play picnics are serving the child's encounter with food on a new level. And the main focus is not on quantity, how much can the child eat of which food with which technique? Is it going to drink the food, or is it going to get it by spoon, or is it going to get solid food? But much more on the quality of the eating situation. That's our main focus, especially in the first 2 or 3 days. We kind of try and help the whole group establish what we call a feeding world, an attractive, non-intimidating world in which the children express more or less the maximum of what they are able to express. And this you probably all know, that children under pressure and in fear are practically not able to learn anything except to try and flee and to get out of the situation. But once children feel happy, safe, and secure, they can express incredible, unexpected progress, and suddenly do things where the parents just say, oh, I can't even imagine that. And we had a very nice example in the last eating school with a 16-year-old lady who actually had been on a tube for the first 15 years of her life. And last year she was weaned, and was weaned onto complete fluid mashed, completely mashed, fluid mashed food, and came to the eating school with her own motivation and said she wants to learn to eat the same food as her schoolmates. And so we said, so what would that be? Give an example. And she said, well, her biggest dream was to be able to one day eat a hamburger. And while she was eating, she was telling us that a little bowl was standing on the table with these little snips, these chips things, and she started munching them, which kind of, it's crunchy, dissolvable things, and she started munching them, and nobody commented and nobody said a word. Her mother nearly fainted next to her, and she was going on and on and on, eating till nothing was in that little bowl of these little chips. And then her mother, quite amazed, said, oh, I just realized that possibly it was my own fear that that something could get stuck, which has been inhibiting this child the whole last year. She suddenly realized that this might have something to do with herself. And I said, why do you think that? Why do you think that this might have an influence? And then she remembered and said that she had had a very traumatic choking episode 10 years earlier, so when the child was much smaller, where she herself had choked on a fish bone. And actually, it had been very traumatic, and she had been to several doctors and several emergency wards and didn't feel really taken serious by all the people she tried to get help from, until she, after 2 or 3 days, went to an ear, nose, and throat specialist, who then took a scope and looked with a video laryngoscopy into her throat, actually found the little bone and was able to pull it out. And the memory of this experience was so strong and so painful for the mom that she without knowing, without being conscious of it, the whole time since her daughter had started drinking purees and eating purees a year ago, was constantly on an unconscious level kind of freaking out because she was frightened that something similar might happen. So she withheld any kind of pieces or even solids. And after telling us the story, her daughter completely unemotionally, she didn't really react to the whole thing and just continued eating. And the next day it was a hamburger she ate, and she left our eating school just eating everything. And it just shows us over and over again that the things the parents have been through with their children, which sometimes is the experience of 4 months of neonatal care if you have a severely premature born child, or a child with repeated episodes of fearing the child might not survive surgery in children with very complicated cardiac problems, and so on. The parents have mostly been through hell before we meet them, and mostly have kind of concentrated the whole emotional burden they've gone through since the birth of their child, mostly since the birth, in something like a nightmare around feeding, because feeding is the meeting point where the parent and the child kind of need to meet and need to succeed. And if there's too much pressure, anxiety, or fear in this interaction, then the parent's mindset very much affects the children. And that's why a lot of our work is, we don't like to say we have to only change the parent's mindset and then the children will succeed, but without addressing the parents' issues and concerns and mindsets, we would not be able to help the children substantially. We might help them in the short-term situation in the eating school, but once they would go home, if you don't achieve a substantial mindset change in the parents, the success will not be able to be of duration. Now, what I forgot, that between these 3 main play picnics, which are at 9, 12, and 5, we offer 2 children parent groups, which are focused on sensory awareness around food. So it's food playing, food touching, food experimenting with food, and doing very, very playful and attractive joint things like building cars from food, building houses from food, making pizza together, making jewelry together, 20 different groups, whilst one parent, the other parent who is not accompanying the child, is in the second group session with mostly only mums or only dads, talking of very different issues which they choose themselves. Sometimes it's quite psychologically focused on sharing difficult experiences and sharing what they've been through, because many of these parents have the feeling that they're living in a world where only they seem to have the problem and nobody else seems to understand the severity or the impact of the issue of the child on their lives. And suddenly they meet 10 other families where, wow, they talk as if the parent feels he's talking or she's talking himself. So these groups are more psychologically, psychotherapeutically supported by our team members. And some of the parent groups are kind of educational, focusing on eating, early eating development, trying to explain to the parents how the transition from breastfeeding to bottle, from bottle to spoon, from spoon to solids actually works if you look at it in detail. And we often realize that these, what we call eating development, is really a chronological sequence of very complex motor sensory skills, of which most people don't even realize how complex the achievement of these skills is if you start at 0 at a much later age than healthy children go through. Because eating development from the healthy newborn to the healthy toddler, maybe at 12 to 16 months, in a child who is completely living in a supportive environment and has never had a medical problem, the children can reach oral independence and eating independence actually at the age of 12 to 16 months. But our patients have hundreds of reasons why this wasn't possible and why their development was concerned with quite other survival issues. And suddenly at the age of 1.5 or 2.5, really independent, whether if they have a nasogastric tube feeding them, or a PEG tube or a jejunal tube, or no tube at all, but maybe being fed with a syringe, or being only able to eat very, very, very selected few foods. And we suddenly realize how enormously difficult it is to catch up with eating development if it's not happening in the time window where it physiologically normally should happen. So one of the questions which we are always asked is, at which age can we start helping your child? And really the answer is as early as possible. If you have an issue troubling, well, the issue of tube should really be dealt with before discharge of the child. But if a hospital setting lacked the structures for tube management and tube weaning and didn't have a team to support the child, then the children, even healthy prematures, can be discharged on a nasogastric tube, which then more or less gets forgotten. And suddenly the child is a year at home and nobody quite knows how to go on with the tube. So we accept children with tubes from the age of 4, 6, 8 months. And that would be the kind of optimal age to come. But the average age the children come to the eating school in average is between 1.5 and 2.5. So mostly we have a group of toddlers, little boys and little girls, who some of them will be able to walk, some of them not. And the groups are very mixed. So we have to kind of help every single child find a comfortable and secure way to integrate itself in the group. Now I'm just going to see what the question and answer are being answered by our medical psychologist, Dr. Passini. And so just continue to use the question and answer. I will continue to focus on the questions which you have sent us in preparation for this webinar. So one of the frequent question is when to start weaning. So if your child has a tube, the answer is definitely as early as possible, as soon as the medical situation for which the tube was given has stabilized. We do not wean children from tubes who still have a big operation coming up in the next 2 months. That would not be a wise timing. And we would coordinate the question of optimal timing, not only with the parents, but also with the treatment team, the local treatment team the child has at home. And this is mostly something where the estimation of the surgeons or the cardiologists or the gastroenterologists have a very important saying in their estimation. And mostly we get the answer, oh, please feel free, start as soon as you want. And in some rare cases, they will say, I don't think it's a so good idea. Could we please wait for 3 months because we still plan to do this and that. Now, one of the also most frequent questions is when parents write to us, how can I get my child to be weaned from the breastfeeding when a child resists all transitions from the breast, or how can I get it to eat more vegetables, or how can I get it to transit from bottle to spoon or from spoon to solid? And in these cases, we understand that the concept of parents wanting to get their child to make the next step is understandable and needs to be, of course, respected from a psychological point of view, but from a practical child development perspective, it's actually counterproductive. Any child which is smart will try to work against the expectations of its parents, because children don't learn to eat because they want to make mommy or daddy happy by learning to eat, but because they're hungry and it's normal. And the more expectation is put onto something as normal as eating or breathing or peeing or doing any physiological behavior, the more expectation is in the air and in the atmosphere around the child, the lesser and the less likely the child will be interested in fulfilling the parents' expectations. Now, you might think this is nasty of the child, or you might think it is painful for the parents. But in fact, if you explain the parents that it's the child's smartness and sense of individual personality, and really a strong sense of personality to say, no, I don't want to do what you think is good for me. I want to find out what is good for me myself. And as soon as parents understand this, not as a deficit, but as something you can also interpret as something positive, they immediately start moving around the child and talking differently, and will not go and say, look, this is how you have to do it, and I'll show you how to drink. The child knows all these things intrinsically and genetically. You don't need a teacher to learn to eat. You only need eating models. So many of these children actually lack the opportunity to sit at a normal table with their family and just be part of a normal mealtime culture where the father eats something and the mother might eat something else, and the siblings might run around and eat or come and go. But we need eating models for the child, but we don't need teachers who kind of have the feeling that the child has to be really shown in a very detailed way what to do. And this approach, we call it the child-led approach. We spend a lot of time and energy in observing the children in how they are moving about and organizing themselves without the interference of their parents. This is very, very, very important, because every single child, and I think we have weaned 6,500 children from tubes, every single child is different. It's a different age. It has a different medical history. It has different personalities as parents. It has a different family situation. And you can't just say because a child has a nasogastric tube, it'll work the same way as another child who might even be the same age with also a nasogastric tube. These two children might even have the same medical condition underlying, but every single child will take a different pathway and need to find its own time for each step by self-motivation and self-regulation. So the regulation of hunger satiety is something which becomes an important issue in the discussion when we're talking about reduction of tube feeds, which is medically supervised every single day. And if necessary, we can discuss whether a child might need more again in the evening if we feel the child is showing weakness or is becoming too fussy. But basically, you can't wean a child without stopping what has been going on all the time before. and you can't get a child to give up its feeding behavior and its feeding routines if we don't offer an attractive change. So that's what really the first few days in the eating school are about, giving the children chances and opportunities to feel secure and happy with each other, and also very much to observe each other in the eating, to play with each other. And sometimes we might show the parents a specific move or make a suggestion, but basically we always try to follow the child and the child's cues. And as long as the child is moving its head away and showing what we tend to define as oral aversion, which is not a diagnosis in its own right, but a reaction of a sensible child to too much pressure. So don't believe if doctors have told you that your child has oral aversion, that that's something like an illness of its own right. It's not. It's a reaction. It's a wise and sensible reaction to something which has not been going good for the child. Now, we are also asked about where do the families live when they come to Graz. They live in hotel or apartments, mostly in apartments, just around about in the circumference of about 1 kilometer, walking distance from the eating school. It's in a very kind of beautiful area, a living area of Graz with a nice pond and woods and a park and places you can take your child for a lunchtime walk. There's a break at lunch, and then the children come back in the afternoon. And the smaller children mostly have a nap in the lunchtime, whilst the parents are either also taking a rest or making a walk with the children. Now, one of the frequent questions was also, do we make liaison? Do we offer liaison with local therapists, which the child has at home, and doctors? The answer is clearly yes. If necessary, we even communicate with the local teams before the child arrives. For instance, in children with a kidney insufficiency, with complex medical situation where we might need to take a blood check during the weaning process, or if there's any kind of medical concern which the parents feel a bit insecure about, then we communicate with, we call the doctors or we Zoom with the doctors or therapists. And that is mostly very much appreciated. And it also helps us to understand into which atmosphere the child will be coming back into after the discharge from our program. Because after the 2-week eating school, every single child and family is receiving another 2 months of continuous online support. And in these 2 months, we not only accompany the child to bring the new achievements securely and safely into its home, back into its home, so to kind of sustain the progress which it has made, but we also take great care, and we find it very important to help the family make a sensible choice of aftercare. And some children might need less therapy than they have been getting, or might need a differently focused therapy. So in many cases, the eating school can also become a changing point for the intensity and the quality of the therapies the child is getting at home. And in some cases, the doctors of the child will also be integrated in the aftercare if we have specific problems. For instance, we had a little boy last fall who was weaned from TPN, from being fed all his life. He was 7 years old, over a central venous line. He didn't have a feeding tube where he got nutrition, but he had a central line offering every night specifically for him composed composition of parenteral feeding, which of course needs to be adjusted weekly, at least probably once a week. And in those cases, we are in contact with the local teams and also with the labs making these special foods, also in children with metabolic diseases who have special diets, also during the eating school. But basically, we try to help them kind of come home smoothly and gently into a new situation, because suddenly coming home after 2 years without a tube can be fine for the child, but might be a little bit making the parents nervous. And what shall I do if today he will only drink 300 and not the advised 400? And then we have to be with them. And this is a daily online support, more or less 24 hours. We do have a few hours in the nighttime when you will not receive an immediate answer, but basically our ticket system, as we call it, is a non-synchronized mutual communication platform, where the parents make questions and answers 2 or 3 times in 24 hours. And also unexpected medical crisis. The child suddenly gets sick or has a high fever or has an accident, shared immediately on this same platform. Now, there was also a professional sending a question about the issue of cultural barriers. Yeah, I'm myself a person who has 4 nationalities and has lived in so many countries that I mostly feel very fascinated and intrigued by what you would call a cultural mix. So a different culture for me, also a different eating and feeding and cooking culture is never a concern, but we do have a complete mix through social families from very different social environments. And yeah, that's like being on a plane or on a ship or in a train with people from different countries, from different perspectives, from different cultures and different languages. Our eating schools usually are conducted 3-lingual, French, German, English. But in the next one, starting on Monday, we have a Dutch family who doesn't speak German or English, so we'll have a Dutch interpreter. Sometimes we have people from Italy, Spain, Scandinavia. So if necessary, if German, English, or French is not sufficient for a family, we have to organize additional translations. And we have to discuss the individual themes and topics the families have. And if any family feels disturbed by another family, it'll have to be dealt with and addressed. But I don't see basically any kind of problem. You have the same issues in every single hospital. And I worked 35 years in a public hospital. So this is not a challenge we can't manage. One question also very interesting is the question whether the success of treatment is related to the individual diagnosis of the child. So the question is, can you wean children with a congenital syndrome or a chromosomal deletion easier or harder than children with a cardiac diagnosis, a singular one, or with a complex syndrome? The answer would be it is not related. The weaning success much more depends on the pre-existing oral skills. So if you have a fully exclusively tube-fed child, which is already accepting sips of drinking or maybe even biting into a cookie, then we are very, very happy, because then the jump into the experience of how to proceed when the tube feeds will be reduced will be not so great as if we have a child independent of the diagnosis, which has actually never, ever, ever had anything in its mouth except its own saliva. That really is something where hospitals and feeding teams are not good yet at offering what we would call non-nutritive oral stimulation. And there's a lot of things which should be done and could be done in the preparatory phase of children who need a feeding tube. And the same is really in the whole population of what we call picky eaters. Mostly the idea to need a change or need help from the outside starts too late. The parents have been feeding one single yogurt or one single pudding for 2 years before they kind of get to the stage of we can't manage this anymore, and then turn towards help. And that's really a shame, because the longer a child is exposed to something which is not considered as what we would say a natural eating pattern, the harder it will be to get it off. And the sentence, which is often said to these parents, well, just wait, when your child gets to school age, it'll happen by itself, is a myth, and it's a lie, and it's a misconception. Nearly nothing changes to the better by itself, unless the child really in a completely new group has exposure to a different way of dealing with food. So we do have some children who, for instance, practically refuse all food at home, but eat in kindergarten or at the nursery or at the neighbor. And we have children who only eat certain things at home and will not touch a single crumb of anything in the public eating situation. So children are very specific, and we just discuss in the first days of the eating school what are the goals and what would be like the best possible outcome, and then what is realistic to expect to happen in 2 weeks, and what will for sure not happen in 2 weeks. And we are mostly very proud and happy if we can help children who are on the tube leave the eating school without needing the tube. But in some cases, when the children have severe disabilities and medical concerns which do not allow to reduce the tube feeds swiftly, then we might need twice as long as 2 weeks to reduce the child's feeds as gently as the medical condition allows. And that's the reason why we have 4 pediatricians, very experienced pediatricians on board, because each of these children has quite interesting and challenging medical issues, which can't be ignored. Because otherwise also the parents would not trust, they wouldn't be able to trust us if we say that doesn't matter. It would be stupid and not good. So my question to the team is, have any other new questions come in from the question and answer in the chat? Yeah, I can go on with the list still. We were asked whether specific diagnoses like children with what we call Costello syndrome or Silver-Russell syndrome children have a diagnosis related or correlated reason why they find it hard to transit from early phases of eating development, like drinking only bottle, to the next stage. And we do not think this is diagnosed specific. We think it has much more to do with how the parents have organized, mostly with very little support, helping their child survive. So for instance, many parents find a temporary solution by what we call dream feeding or sleep feeding, and find it easier to offer a bottle while their child is sound asleep, and not conscious about being fed. And if you do this very gently and very sensitively, the child will be able to even sustain all its nutritional needs during sleep. But of course, on the long run, you can do this for 2 or 3 months. It's very stressful for the parents because they spend all day running after the child and trying to get it to sleep, because only in the sleep they will be able to offer the next bottle. But on a long run, of course, this will not lead to the child learning anything, because the child's wake time is seeing the world in a fully saturated feeling of its own physical self, which is more or less the same as being tube fed without having a tube. It has no idea what goes on in the sleep. It just wakes up and feels good and full, and is absolutely not interested in what's going on in the kitchen and at the table, and will resist any kind of trying to be fed. And in these situations, we have to wean the child from dream feeding. Or if a child is already 3 and refuses to leave mother's breast and wants to be breastfed all the time, that's a different kind of weaning. And really, it's not about tube or not tube, or picky or not tube, not picky. It's about helping children move from a situation where they got stuck, and helping also the parents have the courage and the courage to make a change, which might need a few days of insecurity or of less intake. And this can be very scary. So our job is to try and support the parents and the children, each on their levels, to make these changes. That's really much more our job than needing to adjust to the specific medical diagnosis. Yeah, I would like to ask my team if there's any question I should still focus on. There's one thing Mrs. Dune just asked: do you have any suggestions for how to address as parents concerns that the child will not maintain its weight if the tube feeding is reduced? Yes. We are very, very open in this respect. We tell the parents there is no wean without weight loss. The best possible outcome of reducing the tube is that your child will plateau in its weight for a certain time of 2 or 3 weeks, even possibly a month. That would be the best possible outcome. It does happen in maybe 5% of children that they, even under the reduction phase, gain weight, but that's very, very rare. Mostly the children will lose, and the parents have to be informed very openly about that, 5 to 10%. And exactly this weight loss happens to every single newly born healthy newborn. A child born with 3.5 kilos will lose 0.5 kilo or nearly 0.5 kilo in the first week of life, transitioning from intrauterine life to the mother's possibly breastfeeding or bottle feeding, when the ability to really take full volumes is not developed yet. And people find this utterly normal and will have to bring up the patience to let this happen and to just wait till the child has managed to get there. And the same is with the weight loss in tube feeding, and exactly the same also in dream feeding weaning, or weaning from the breast, or weaning from less bottles. If you have a 2-year-old living on 6-7 bottles a day, it will lose some weight, but we very much take care to calculate whether the child's onset weight is already critically low, and then we are even more careful and gentle, because we have some children starting the wean in a state of practically malnutrition with a BMI of 12-13, which is of course not good, but sometimes fully exclusively tube-fed children suffer from malnutrition because they vomit and nobody can achieve the sufficient volumes. So whether you start with a BMI over average or nearly critically low makes a difference, but still you will have to inform the parents openly that the weaning will have a high probability of costing some weight in transition. This phase will be at most, I would say, 1 to 2 months. We call it the timeout. We tell the parents in the next 2 months when the tube is out, give your child a chance to kind of enjoy tube-free life now, mostly developmentally. They actually jump forwards. Language, communication, expression, social interaction. Imagine a child who spent 20 hours per day on a jejunal tube suddenly being free to explore its world and run about the house. So a lot of things change when once the tube is out and once the tube feeds have been discontinued in the case of a PEG, which we don't pull out on the last day. But the parents have to learn to kind of focus and enjoy other developmental progress and not only be only concerned and fixed on the oral intake issue. Yeah, we are slowly coming to the end. If the next question is, my child eats 20 to 30 mils and then refuses to drink more on the bottle, regardless how much milk was given via tube. Okay, that's a question which is very, very expectable. Children do not get hungry. Tube-fed children do not get hungry in a time window of 2 to 3 hours. We are always too impatient, and we would have to put the children on 0 tube for more than 6 to 8 hours to expect more intake. So I would say any child drinking 30 to 40 mils is able to be weaned in any case, for sure, but we will need to, under medical supervision, reduce the tube feeds quite considerably. And there's a question from Mrs. Leah. Okay, I didn't quite, this was too quick. I think at the moment our time, unfortunately, is over. I would like to very much thank you all for participation this evening. And I would like to invite the parents in our audience to use the opportunity of our free evaluation. It is free, and you get in contact and can discuss your own personal problem of your child in these free evaluations. Mostly we have a bit of a waiting list, but it is possible to offer the free evaluation mostly within 2 or 3 days. And we can only invite you if you have the feeling that the eating school of NoTube might be an option for your child. We would be very, very happy to see you. We are fully booked out until July this year, but in the summer, we're doing a course every single month, and we still have free spots for August and September. So feel invited and welcome to continue your contact. And we thank you as a whole team very, very much for your participation this evening. We also have a helpline called help@notube.com, where also professionals can address us if they want to discuss specific patients. Thank you so much. Thank you, everybody. And I wish you all a lovely and good, happy, relaxed weekend. Bye-bye.